We're going to round out the last session with expanding treatment planning with a few presentations and our last panel of the day. So I'll introduce our first speaker of this panel, Adam Bayliss. He is the Associate Professor and Director of Physics Informatics in the Department of Human Oncology at University of Wisconsin in Madison. So welcome, Adam. There's your clicker.
Great, thanks. Well, good morning, everyone. Thanks for coming and thanks for sticking around. Hopefully the Miami airport isn't too crowded on the way out. I'm sure we'll all be just fine. Oh, that looks like a proper laser. There we go. Yeah, my name is Adam Bayliss. I'm a professor at the University of Wisconsin. I have a couple of colleagues here who work pretty heavily with me on these projects, Dr. Morris and Christian Velton and Wolfgang Tomei of Montefiore. I'm going to be talking about temporally modulated pulsed radiotherapy planning in RayStation, which has the distinction of being kind of inverse flash. I know flash is really exciting these days, but this is, if flash is as fast a radiation as you can deliver, this is more like soft white or sepia or something like that. It's as slow as you can deliver the radiation. So the challenge that we meet in this regime is mainly with glioblastoma. It remains a super high mortality disease with a median overall survival of around 14 months. And recurrence is almost unavoidable. The mean progression-free survival is around 7 months. Most relapses occur in the prior high-dose field, so the sort of 90 to 95% of the radiation dose is where the recurrence tends to occur, and it's also where the toxicity risk is highest, from necrosis and multiple different kinds of myelopathies. And so the toxicity risk is greatest where the recurrence is most likely, and so we can't really just escalate the dose. There's been a few different trials trying to escalate dose in glioblastoma that haven't been proven very successful. And so what we really need is a method to increase the radiotherapy effect without increasing the dose to normal tissue. And so if that's the problem, the next question is sort of what can temporally modulated pulsed radiotherapy do for us? And so I'm just going to present a few curves here. If you're not familiar with hyperresistivity, it's a phenomenon that occurs at very low doses, around less than a gray, down to 30 centigrade or so. And what you're looking at here is the normal linear quadratic modeling, where each one of these points is 10 to 12 different measurements with glial cells in vitro. What you're seeing is the dotted line is the projection of the linear quadratic model, and this is versus the surviving fraction. And you see this dip here that occurs at low doses is an unaccounted for increase in cell kill that seems to exist for many different kinds of tumor cells at low doses. And there's been some modeling that Dr. Tomei and Dr. Howard did in like 2007 to sort of try to explain that increase in surviving fraction, and it more or less has to do with it more or less has to do with the potential of different cells to be in a dividing the different division cycles, the G2 and M cycles. And because the cancer cells tend to be dividing more than normal brain tissue, they are a little bit more susceptible to some of the alpha damage that comes from that could potentially make them more radiosensitive. Above a gray or so, you get right back into radio resistivity, and the effect seems to go away. And so the hypothesis here is to try to use pulsing, use small doses of radiation at once to deliver the same overall dose, but in smaller quantities to sort of keep the cells in this hyperresistivity or hypersensitivity region. The theoretical models sort of predict a potential of enhanced alpha killing in the glial cells between 16 and 70%, which they cite mainly to be cell cycle effect. And then there's a normal tissue benefit as well. Normal tissues tend to be able to repair a little bit better, especially the sublethal damage. And they feel that the modeling shows that the potential reduction in cell killing from the beta term is around 7% in the normal tissues. So there may be a theoretical advantage to this. I embedded my questions right in there, so we'll skip over those. So how do you deliver temporally modulated pulse radiotherapy? Well, it's the same total dose, but you break it up into 3-minute intervals. So you deliver about 0.2 gray over a 3-minute interval. And what that does is it gives you an effective dose rate of about 6.67 centigray per minute. You can also do this with a continuous low meter rate delivery, like some of the Electa systems. You can directly program in the meter rate. It's been of mixed use for us on the true beams. MLC motor drift and thyratron wear tend to be experienced with really low dose rates, sort of the 5 MU to 10 MU per minute dose rates. And so we've opted for a segmental approach. And so here's just a quick example. If we were delivering sort of a standard hypofractionated GBM treatment at 2.67 gray per fraction, we'd break it up into 13 to 14 pulses of 0.2 gray. We'd wait 3 minutes between pulses. That's what the egg timer here is for. They'd start the radiation, start the clock, and then at the end of 3 minutes, the radiation would be delivered in the first minute or so, and then they start the next pulse directly after the egg timer pops off. So one interesting thing that'll be happening as a result of a bunch of phase 2 data that's gone into this is that this year a new phase 3 trial will be open, and it's a pretty exciting trial because essentially we have a group of patients that don't tend to do well on temozolomide, which is kind of the standard of care. And so this arm will randomize between the temporally modulated pulsed radiotherapy, TMPRT, versus just the normal standard fractionation. And so this will be the first phase 3 data that is available for this technique. So if we move on, so the planning constraints. So this trial is set to open, I think, in the next month or so, and it starts accruing in June. There'll be two possible radiation regimes. There's 43 gray and 46 gray and 23 fractions with a sequential boost, and then there's the hypofractionation in 15 fractions. Their coverage requirements are they're pretty stringent on obviously the P90, the D95. Is pretty normal, but the high dose, the 10% and the D max are pretty strict in the trial, and there's limits obviously on all the critical organs and the planning risk volumes. So the planning problem really isn't dose coverage. This is just sort of normal par for the course in terms of glioblastoma treatments. The issue is how to make this pulsing structure work in RayStation. And you know, what you're seeing here on the top row is just a 9-beam standard step and shoot plan, and obviously the very beautiful and slightly distorted for effect DVH here. Imagine all the dosimetrists wish they could just squish that when presenting, but yeah, the steep DVH, and so we would think that this was a pretty normal uniform delivery to the PTV. And if we draw a line just through the isodose distribution and we look at the dose profile from that, it looks nice and flat. But of course, when we break it apart into all the separate beams, many obviously the beauty of IMRT is that different beams contribute different amounts of dose to different parts of the target, and the whole sum is a nice uniform line dose, but in fact we have multiple different beams with very non-uniform deliveries. The goal with this technique is to deliver exactly the same dose in the 3 minutes to the entire target, and so that becomes kind of a bit of a trick. And there's a couple different solutions that we've got here for it. The first is sort of the standard recommended, the trial workflow, which is to optimize a single low-dose beam at 0.2 gray equivalent. So single coplanar IMRT arc, and then you get the plan so that you're happy, and then you duplicate this arc the appropriate number of times to get to the full dose per fraction. An alternative workflow which I came up with is to optimize the full prescription plan directly, but use something new in RayStation 2024, which is a beam-specific objective, and enforce 0.2 gray per beam. And so with the example geometry that I've chosen just for the demonstration here is a 10-arc SRS template. This is the configuration that we would normally use for an SRS treatment with 5 different couch angles and pretty large arcs. And so the common elements is that both of these 2 different strategies that I'll be showing you here use scripted beam placement, scripted structures, objectives, scripted smart arc collimator. So I cheat and flip it to a 3D plan, get smart arc collimation from it, and then flip it back to VMAT. And then a post-plan validation, again, scripted per dose. And so all of the results that you'll be seeing are all just literally just running from input files and just entirely scripted. So again, just sort of hammer home the point, the standard plan has, each pulse is inherently the 0.2 gray over the entire target because the whole plan was optimized for that single arc. And what this does is it does create some minimal degrees of freedom. It creates a nice stable optimization, but the conformality and the homogeneity are driven by a single solution. In the beam-specific optimization, each pulse is enforced via the optimization only. You do get increased degrees per freedom by virtue of the fact that we have multiple different beam angles. And the pulse equality is verified beam per beam. So this is a process that you do at the end of the plan. That's another question there. So this is just a quick overview of what we have scripted for the dosimetrists when they pull this up. They get a series of questions. Essentially, they got to pick out the treatment planning order that the physician used for the treatment. They put in the dose and what the appropriate target is. And then set the beam set, which they choose based on the number of, based on the dose per fraction. So if I had a 2 gray plan, I would choose a total of 10 beams at 0.2 gray per beam. If I had the 2.67 centigray or gray hypofractionation, I would choose a 13 to 14 beam arrangement. And so these are just templates that are loaded. There's a few different manual steps here. I apologize, you won't be able to read them, but essentially they have to go in and do some things that I don't know how to script, like block the eyes and to insert, well, the couch is inserted, but to make sure that the couch is placed in the appropriate place, to put in some fiducials. And once that's done, then they just hit play, and they come back in between 5 and 30 minutes. And they have a fully optimized plan. So all of the planning structures, the rings, all that gets made. The optimization itself runs through a sequence of different warm starts. And then they end up with a plan that they can use at the end. And then the last little bit is another script that computes the suitability of the PRDR of the TMPRT plan here by looking at the total dose, obviously looking at the total dose and then looking at the dose per beam, looking at the max dose within the beam to make sure that we don't have large regions of hot spots inside the target. So that's one of the nice things about RayStation is the whole process is is scriptable. And in fact, we use the same code on our head and neck and spinous BRT and whole brain hippocampal avoidance, and anything that you can think of that you can template, we can do the same way. So here's a comparison. On the left is the single segment plan, and on the right is the beam specific objectives. Just looking at things, obviously you can see, because this guy's coplanar, I have really nice sparing of the apical, the supracranial brain there, but obviously I have some more splaying of the intermediate dose in the coplanar direction, whereas the vertex arcs give you better sparing there. So this is what you'd expect with the improved geometric access from the vertex beams. You end up with a more even fluence distribution. I wouldn't say, if you look at the CTV DVH here and the PTV DVH, I wouldn't say that it's remarkably so, but it's enough to be statistically significant. The brainstem dose in the solid here is the beams is the standard plan, and dotted is the beam specific optimization. You can see that you end up with, as you might expect, more coplanar dose in the brainstem itself, and similarly with the optics and the brain minus PTV end up with a little bit more volumetric dose from the coplanar field, and so the vertex beams enable some of the sparing there. It's important to remember that the trial is going to be is the first radiation that these folks have had. What we've traditionally used this for in the clinic is reirradiation. So someone who's had a GBM recur, or someone with an angioma and had a recurrence there, because it spares the theory is that it spares the normal tissue a little bit better. But this will be a primary, the first radiation that the patients have in this trial. All right, so here's some more curves here. What you're looking at on the top row are just the differences in the orange here are the beam-specific objectives, and the blue is the standard plan, which I've just called the CC0017 planning. You can see that for the most part, they have pretty comparable D95s. This is not surprising. But the D10, the 10% hot for the standard plans are a bit hotter, and the D max for those standard plans are a bit hotter, and so the beam specific seems to win out there. In terms of the D95, the plans are scaled more or less. So the single segment planning is scaled directly to 20 centigrade, and so obviously that's going to be a nice uniform line. This is 44 patients, by the way. I don't know if I mentioned that, but one of the nice things about when you've scripted something up is that you can just load things in sequence, and so I just loaded up 44 patients and ran this study on 44 overnight, and came back and then did it again and again and again, and then eventually got results. But eventually, you can get something nice out of it. The D10, D10 here for the beam by beam D10 is a little bit varying, and the D max for the beam by beam analysis is also varying. So sorry, up here is the plan metrics, and so you can see that. The overall plan doesn't really tell the story here. There's actually some breakup in the different beam-by-beam analysis when you break it down for the beam-specific objectives. Interestingly, if you look at the modulation using the Massey formula, so you essentially have a term here which is related to the perimeter of the segment-by-segment analysis. It looks at the number of MLC leaves, adjacent leaves, for example, to see how much variation there is between adjacent leaves. And then there's another term here that looks at the overall area of the segment. And so a low MCS score means that it's a highly modulated plan, whereas a high MCS, if I had a conformal beam, a pure conformal arc, it would have an MCS of around 1. And so you can see that there's like a bimodal distribution immediately in the standard plan. So these are just one beam that's been optimized to give you 0.2 gray versus the beam-specific objectives. And what that's of course saying is that the beam-specific objectives are considerably less modulated than the single plan, and that's because this single beam has to be doing a lot of work in the optimization when it's the only variable there. So this is just a breakdown of the two terms here. This is the perimeter term here, the leaf sequence variability. You can see that again, similar story in terms of the beam-specific optimization. It's not particularly modulated, but obviously the main term that is dominating the Massey analysis here, the modulation complexity score, is really the aperture variability, where small apertures are being used relative to the mean aperture in the single arc solution. And if we look at the homogeneity, this is the D2% minus D98% over D mean. This is what the trial uses to report homogeneity. They're both pretty comparable. Some deviations out here to 0.03, but certainly all a lot less than 0.1. So these are pretty homogeneous plans. This is a delta analysis, so because it's run on 44 patients, I've got 44 different comparison points to use. The curve on the left here is the Paddock conformity index. The definition's given here. It's just the intersection of the tumor volume with the prescription dose squared over the tumor volume times the prescription isodose volume squared, or not squared, just multiplied together. And you can see that they both have conformity indices of around 0.9. This is kind of where we want to be, is a bit above 0.8 to 0.9. You can see that there's a lot of conformity loss in many of the plans here, and that's not surprising. These tend to be plans that have a lot of overlap at the brainstem. There are a lot of overlap at the optics, a lot of different organs at risk that need to be spared. And on the right here is just the point-by-point Paddock conformity index, and you can see essentially this is a delta. This is a subtraction of the two, and so red means that the beam-specific objectives have a higher overall conformity. Blue means that they have a lower overall conformity, and so they're obviously a little bit more conformal in the beam-specific objectives. This is just a sort of a more busier graph, but it's the paired difference between all the subjects. So this is 44 different cases here, and these are just the different metrics that get evaluated in the clinical trial. So you have your beam set D95, which you can see is a nice gray line here. That's to be expected because this whole thing is normalized to D95. There really shouldn't be any difference. And then you see your the beam set D10, the beam set max dose, and we just kind of move through organs at risk here. The spinal cord probably is the one where there's the most variation. Again, this is showing you that the spinal cord in the beam-specific objectives is hotter than the single segment plan, and it's probably just due to some different weighting with the objectives and the objective function. Nice thing about this kind of a plot is that you can look at a lot of patients at once, and you can see sort of where your outliers are. This is normalized by the standard deviation within a goal population. This is Z-score, and so this is a good way to plot a bunch of patients at once and look for outliers, see where you might have issues with a given plan template when you're using it. So the conclusions. Both of these workflows generate clinically usable TMPRT plans in RayStation. The single segment plan best preserves the intended 0.2 gray biological dose. So this is what the trial is recommending. The beam-specific objectives produce a nice geometric freedom, better conformality, better hotspot control, probably, if I pushed on it a little bit more, better objectives on the normal tissues. So the trade-off is really, structural pulse equity and a sort of an optimization-driven redistribution. The beam-specific objectives reports a very explicit beam level verification, or requires a very explicit beam level verification. You've got to go back in and make sure that these all meet. But it tends to be an acceptable strategy when high doses or volumetric doses or organ at risk limits really can't be met. So yeah, that's the status of this trial, and I'll be happy to take any questions if there's time.
Thanks, Adam. Great presentation. I have a question, actually. So Wolfgang and I talked about this back in December, and his question was whether anything had to be changed in the physics parameters in RayStation, or whether the beam-specific objectives were sufficient. Do you have to do anything to make sure it's deliverable?
Yeah, we have done a lot of validation of this in RayStation already. We've got a paper out about it, looking at sort of the pulse-by-pulse analysis, and a lot of work in GAF chromic verification that low-dose GAF chromic still works, and then just some delta 4 analysis as sort of standard diode array. And the bottom line is that if you were to deliver continuous low dose rate, like say on an Electa where you have to dial in, you would dial in like an 8 MU per minute sort of delivery, you'd want to check the overall dose distribution and pulse stability and things like that. It's been a while since I looked at that on an Agility, like 10 years, and there were issues with startup beam and stuff like that on the Electa when I was first manipulating those. I don't know, I think a lot of those have been resolved, but it's been a while. On the true beams, it's very stable. We deliver these at 100 MU per minute, and so obviously that's right in the middle of what normal VMAT delivery is on flattened beams. And so there's no additional verification is really kind of needed other than normal QA that you would do for a true beam or for an Electa that's been run at a nominal dose rate. So this sort of segmental approach, which is I think why the trial kind of used it. The beam-specific objectives don't really drive anything other than the need to verify that they still meet the per segment dose, the pulsing dose. So you want to verify that every beam essentially covers the target, and covers the target without producing large hotspots within the target, and delivers the pulsing dose of 0.2 gray inside. And that's actually pretty straightforward to do with the restrict all beams individually. It creates, that tool is fantastic. It for this and a few other things that we use it for, it takes the objective that you put in, let's say I want 60 gray to a target, and it says, okay, I'm going to make 60 gray divided by the number of beams. Every beam is going to contribute exactly the same amount, which is usually a terrible idea for a VMAT plan, right? You're giving up your ability to weight beams, but it's perfect for this. It actually works pretty well for a few different other places that we've used it, where you maybe want to use do a SRS planning, but you want to not let one arc sort of dominate the target coverage, and so yeah, it works well. No, the beam-specific objectives don't drive anything new.
Okay, great, thanks. That's all we have time for. Sorry if I took the only question, but
sorry
hopefully
if I
that helped.
too long.
Thank you, Adam.
So much, Adam.
Thank you.